you're putting yourself out there, and that's
Yes.
something scary, and that's something new, especially, if you're that young and then you're in high school, and you have a lot of things influencing things like that. Like, oh, like, does this seem embarrassing? Am I going to be judged? Is this going to be weird? But I think that being vulnerable and then allowing yourself to just explore and step out of your comfort zone a little bit will really pay off later on. Like, as long as you're, doing it in a safe and a structured way, it's really important to get yourself out there as earlier as possible, so that later down the line your options really open up and you get a more broad sense of what is really out there, and what is possible.
Hello and welcome to the Patient to Professional podcast. My name is Dr. Nick Despotidis, and I've had the privilege of examining thousands of children who are now adults through the years. Today, I have the pleasure of inviting one of my long-term patients. She's been my patient for over 14 years, Rashi Shukla. Rashi has a very interesting career, and when I examined her recently, she was nice enough to come onto the podcast to tell us not only about her career, but also the path that took us to this career. Rashi, thank you so much for joining the podcast.
It's a pleasure to be here. Thank you so much for having me.
So Rashi, I'd like to start with telling the audience, what do you do? I was fascinated when you were telling me about this in the exam room.
Yeah, for sure. So in a nutshell, my position is called a clinical account specialist, but what I do is electroanatomical mapping for ablation procedures in electrophysiology, which is a subset of cardiology, that deals with cardiac signals, and then how to treat different various clinical issues that may arise from those signals being not in tune or not supposedly working as they should.
So,
Yeah,
so when patients have some type of arrhythmia with the heart
right.
and medication is not effective in controlling that irregular heartbeat,
Mhm.
they often get referred to an electrophysiologist, a cardiologist who has a specialty in ablating, or is that killing some of the cells or nerves?
Correct. So you map to kind of understand and get a sense of where the arrhythmia is originating in the heart, and then you burn that tissue or those cells in that area to treat it through ablation.
And what I didn't realize, even though I'm a physician, I'm an optometrist, is behind the scenes, you're doing so much work that allows the cardiophysiology to diagnose and treat patients.
Right. Yeah. It involves, it's a lot more than I feel like people might expect or even know about, because this was definitely something that I was not aware was a career option at all going into it, until my uncle, who's an electrophysiologist himself, told me so. And so I was fortunate enough to have someone like him there to sort of guide me and introduce me to this field, and I'm really enjoying it so far as a result.
So tell me what you typically do. What does your day look like when there are procedures? I know from a lay person's perspective, these procedures can be long, correct?
Oh yeah, they can range anywhere from an hour to maybe 6 or 7.
My
It
gosh.
just depends on the patient, their anatomy, the type of ablation being done, because is it in the atrium or the ventricle? All that stuff plays a factor in how long it can be. But as far as my day goes, you start off, you get to the hospital. Um, Usually these procedures take place in the Cath lab of the hospital. You try and get a sense of what the schedule is like for the day, if there's any procedure before or after yours. We have a bunch of equipment, like a lot of computers, generators, all those things that you will be taught how to operate and set up in the operating room. And then once you go and set everything up, make sure all the equipment's working well, there are no errors in the software or the system or your products like the catheters. Once that's set up, then the nurses are finished setting up the table and prepping the patient and the table. Then the physician will walk in and we begin the procedure. And that's, depending on how long it takes, once the procedure is finished, and you're finished mapping and diagnosing the heart and then ablating it, you wait for the patient to come off the table, everything to be cleaned up, put away properly. And then you can either go home or you wait to see if there's any other ablations that need to be done, set up for, so on and so forth.
So you get there long before the surgeon, it sounds up. Is that correct?
Yes.
And you're setting up, I
So
guess, your computers, your software, hoping there are
right.
no bugs, I'm assuming, or hiccups.
Yeah. Oh yeah. So there's a whole lot that goes into just troubleshooting itself because
Right.
not just beforehand, even during the procedure, there
Oh my
can be a bunch
gosh.
of things that'll just suddenly go out of whack or go wrong. And it's not always clear what's causing what. Like sometimes the error will present you with one thing that you think is related to one set of equipment, but then you'll switch a setting or something and something completely different, and somehow that resolves it. So,
My goodness. So you have to not only have the knowledge, but you have to work under pressure. There is someone
yeah.
that is having the procedure in real time,
Hmm.
and there's a glitch, and you have to stay calm and try to troubleshoot it.
Yeah, it is a bit time sensitive in those situations. And not only work under pressure, but be openly communicating with the physician, who for obvious reasons may not necessarily be um pleased with the fact that something is suddenly going
100%.
wrong.
Yeah, for the audience out there, if you've worked with surgeons, there's all different types, and we can't do a generalization. But when something goes wrong in their operating room, more
Mhm.
often than not, they don't take that lightly and they get very upset.
Correct.
You
Yeah.
know, not directly aimed at someone, but they're upset. And then I've been in those situations very tense. So
Hmm.
so kind of in a layman's terms, what are you mapping? How do you do it? Are you looking at screens with the surgeon? Is the patient awake? Give us a kind of drama of what that OR or that cath lab looks like, cath lab.
Yeah, for sure. So, first and foremost, the way the technology works is the patient will be placed with a certain specific set of patches that are a reference, and you have a magnet underneath the table where the patient's resting that creates a magnetic field that'll allow you to actually visualize, the catheters and things as they're being put up in the body. Um, so it's not like open heart surgery where the doctor is actually physically able to see, where the catheter, how the catheter is going up. A lot of times they'll insert the catheter through a groinal puncture, and then they'll have to rely on our technology and the field and the maps and the chips inside the catheters to be able to see where in the heart they are. And not only that, but they'll also have to rely on the actual signals and how they're appearing on the catheter themselves to be able to understand where in the heart they are. Are these atrial signals we're looking at? Are they ventricular signals? How they line up with, like an EKG placing. So it's all looking at not only like a 3D rendering of the heart, but also looking at a bunch of different signals and being able to interpret what those signals mean. Whether they're moving rapidly or it's in a normal sinus rhythm, so on and so forth. So a lot of knowledge involved of cardiology, and, just knowing what those different things mean. So typically, once the catheters are placed in, there are two different types. There are ones that purely diagnose, so all they do is show you what the signals do. And then and they also help you sort of create like a 3D reconstruction of the heart. So the physician will put the catheter up, they'll start to move it around, and it creates like almost like a 3D shell of
Wow.
that chamber of the heart. And then on top of that, you can also collect points and see different signals as they are in real time in that patient's heart in those positions. And then once you do that, there are ablation catheters, which are specifically designed to deliver the therapy, whether it's radiofrequency, which is like burning, or cryo, which is like freezing the cells to kill them. And then there's also even a new technology that's come out called pulse field ablation, or PFA, that a lot of physicians are using now. So we kind of combine and use all different types of catheters to take a look at signals, see where they are specifically in the heart. And then once we get a general topographical and even like anatomical sense of what's happening, the physician makes a decision like, okay, this is the spot I want to ablate
Right.
here. You burn there, and then afterwards they do a set of procedures, like pacing, a specific catheter in a specific spot to kind of generate signals there and see if we've affected it and treated it, and then move on from there.
Fascinating. Is the patient awake during this, or are they under general anesthesia?
It depends. So, for example, like one type of ablation is for atrial fibrillation. For those, generally the patient goes under anesthesia and they're not awake at all. But there are other instances where sometimes, in order to be able to understand where the signals are coming from, the patient has to be slightly awake. Because if you put them under too much, then the signals will stop, and then you won't be able to really understand the origin of them. So you need them to be like firing in order for you to map it. So I think it ranges from procedure to procedure,
Right.
but they're never like fully awake. There's always slightly sedated.
Okay.
Yeah.
So let me just to close on the procedural, just because I'm so interested in this. Is there a conduit? Do they pass a conduit and there's different catheters? Or does this main catheter have the ability to take the topography of the heart, visualize the heart, monitor the heart's rhythms, and also ablate different spots? Or do they remove the catheter or put another one in to do the different procedures?
Yeah, so a lot of times there's several catheters up at once.
Wow.
There will be one that's solely designed for delivering the therapy, but they'll still also have the catheter that they put in beforehand that created the anatomy and looked at and mapped the signals. And then there are other catheters that are purely there for diagnostic purposes to just pace or like get the patient out of a fast rhythm if they spontaneously go into it or something like that. So it can range anywhere from like 2 to even 4 or 5 catheters in the heart placed in different locations at once.
Fascinating. That it really is fascinating. So tell us a little bit, how do you get here? If you interested in medicine, did you have to go to medical school, college? Give us your, where you had to go to get to that cath lab.
Mhm. So for me personally, I would say a lot of my coworkers and myself started with a degree in biomedical engineering, which I think would be especially useful, or even a related field. If you're really interested and you're maybe coming from a different background or a different major, I think it's fairly easy for you to learn and get into this position. And I think that's one thing that's especially unique about it, because when I was undergoing training, there were quite a few people who, like when they introduced themselves, were like, oh, I used to be like a business major or something, which you wouldn't
Really?
expect. But because of the way Johnson Johnson, which is where I work, trains its employees, they give everyone a good baseline foundation of the knowledge, the clinical knowledge you would need to be able to cover cases. So it really just depends on, I think, your interest. For me, I started with a major in biomedical engineering. After that, I was not really sure where I wanted to go career-wise, and I was kind of torn between going into medicine or, pursuing a career in biomedicine, whether it was research or otherwise. So I actually then completed a master's in medical physiology, which gave me, more than enough of a background to be able to
Right.
go into this position. And then that was when it was once I completed that I kind of realized I wasn't really interested in becoming a doctor or a physician. And I was still very much interested in technology and biomedicine and, evolving therapies. And just research was something I was purely fascinated in. So I saw that this was a field in which not only are there emerging therapies and great advancements in the research still being actively done, but it also combines that use of technology and medicine. And then you're also involved in a clinical setting in a hospital working to treat people. So that was what fascinated me. And that's kind of how I was sort of geared towards it and why I think my uncle even recommended it to me in the first place after hearing kind of where I
What's
was.
involved? Yeah,
Yeah,
there's a good mixture of a lot of things there, including clinical interactions.
right.
So if a student, a college student says, wow, I'm interested in a health related field, but I'm not up for the MCATs and the whole rigor of becoming a physician, but I do want to be involved clinically. How would
Mhm.
they apply to this? Do you need an undergraduate degree?
Yes. So I'd say you would need to be at least a junior or above to either become an internship or have complete an internship for this kind of position or apply if you're a senior. And one of the things that I would recommend if they're unsure of what really is involved and they would like to get some exposure into it is there are definitely ways for people to shadow and maybe follow someone like myself, go for a day, see what it's like in real time. And I think the best way to do that is to just look up similar positions, people in similar positions in places like LinkedIn, which I think is a great resource, using people, especially who are alumni, who are probably,
Right.
open and willing, and very understanding, of you being a senior or a student and wanting to get some more opportunities. Um, I would just find people on LinkedIn and just send a quick message like, hey, I'm so and so, I saw that you do this. This really fascinates me and I heard about it. So I would love to see if you're willing and open to me shadowing you sometime, or if you have any recommendations for people who would be willing to have me with them for a day. And I think that's a great way to sort of get yourself involved, at least show that you get the experience and then move on from
I
there.
think that's great advice. I
Yeah,
really do. And I think that would be for any field.
right.
And use your alumni, use your connections, and be
Mhm.
prepared for rejection. I just want to warn maybe you have to send out 100 to get a handful of responses, but that's life.
Yeah,
Not
I
like
agree.
school where you submit a paper and you wait for a response or grade. That's
Right.
great advice. It really is. So, what does your typical week look like? Do you work weekends? Do you work 9 to 5? Do you work every day? Give us a feel of your lifestyle while you're at work. How does your typical week look like?
Yeah, so I think my week is pretty flexible, which is, really fortunate. I'm really thankful for that. A lot of it is dependent on scheduling. Unfortunately, the way the scheduling works is you really don't get a proper sense of how your week will look like until perhaps the day before, because
Okay,
a lot of case scheduling happens last minute, like if there's an add-on case or something, you may be called on a last minute basis, but you can also get like a general sense as far as the week's schedule just by looking ahead. There are I work from Monday to Friday. It's not necessarily a 9 to 5 because again it's purely dependent
sure.
on when the doctor has scheduled the procedure. So you could be scheduled for a 7:30 a.m. procedure, or maybe your first procedure of the day starts at like 1 or 2 o'clock. And even then, a lot of it is subject to delay. So let's say, you are scheduled for a later procedure, but the procedures before that have been running late. You may be getting there early, but then still having to wait an extra few hours before your actual procedure starts.
And if that procedure takes hours versus 1 hour, you have to obviously say the duration. So if your
Right.
procedure is scheduled at 1, the lab is backed up, you get in there at 4, 3, 4. Does that happen sometimes?
Yeah,
And
I
then,
actually just had one yesterday where I was scheduled for something. It was scheduled for 10:30. Procedure started at 2 o'clock. So it
yeah.
it can really just depend. The first procedure
And
was
if the
on late.
patient is unfortunate, or you're unfortunate, and it's a 3, 4 hour procedure,
Yeah.
you have to stay there the duration. And like you said, wrap up and make sure everything is put away appropriately, etc.
Right. So just because the physician says, okay, case is over, it still means you have to wait for them to, get the patient like off the table, get all your equipment off and out. Then you have to make sure everything shuts down properly, put it away in its appropriate spot. And only then are you really able to leave. I'm assuming there's no other cases for the day. And there are instances where, some days you aren't scheduled for anything. And on those days, it's kind of like, you wait to be on standby just in case somebody has
Sure.
an emergency or can't make it to their case, so you need to cover for them. But, typically if there is no case scheduled for you and you're in a field or in a pod where a lot of people are already covering, and they have double coverage, like sometimes 2 or 3 people assigned to the same case with the same physician, then you may get a day off here or there, which is
Okay. A more
nice.
relaxing day.
Yeah, yeah.
So how many patients do you typically help treat in a given week? Is it 1 a day, 2 a day on average? I'm not going to hold
On
you to
average, I would say, at least in my region, 6 per week
6.
for me
Wow.
personally. But then there's like, imagine like that multiplied by however many cases are happening a day, which is on average like 10 to 15. So, you know, it ends up amounting to a lot as a cumulative whole. Even if
Okay.
you
Right.
yourself are covering just 6 cases for the week, then it's like, okay, there's 20 other people in your group who are also covering 6 per week. So that's a lot.
It's a lot.
Yeah.
And are you salaried, I'm assuming, or do you get paid per patient?
I'm salaried, and then
Okay.
on top of that, you're eligible for more compensation depending on how your pod performs in terms of sales of, the catheters that the doctors are using and the case coverage. So that gets added onto that.
Got it. So tell me your most exciting case. Is there one that you're like, oh my God, I think I'm going to remember this forever? Do you have an
Mhm.
experience like that you want to share with the audience, with the students, like where you left? I'm sure it's how you left with your chest out high and happy and saying, "Wow, that was awesome."
Yeah, this actually happened about a month ago. There was a case where it was scheduled as a routine AFib. So you do your typical like what the doctors like to do is isolate the pulmonary veins and the left atrium. That's like the typical, treatment. And then after that, they pace the heart to see if everything is good, and if they induce anything. So sometimes you can get the patient into an atypical flutter rhythm or like an atrial tachycardia, and then you'd have to spontaneously and suddenly set up a map that out, figure out where that's coming from, and treat that on top of the atrial fibrillation that they were there for.
Wow.
So we did the whole like isolation of the veins, and then during the physician's waiting period, they induced an atypical flutter, and it seemed to be coming from the left atrium, and we mapped it and then realized that, oh, it was actually coming from the right atrium. Just depend the way the signals looked,
Sure.
none of them were really originating from the left side. So then she has to pull the catheters back. We started to map it on the right atrium, and then we found the spot, and there's a bunch of different tools and softwares that you have installed to be able to really pinpoint where that target spot critical isthmuses that's creating the flutter. So there was this one that I had been learning that she was not really used to using. And so as an experiment, I was like, hey, Dr. So-and-so, here's this tool that I know a couple other physicians like to use to be able to see where this is coming from. Why don't I enable it for you? And this was also new for me because as I'm pretty new as a mapper, but one of our responsibilities is to get physicians comfortable with
Sure.
newer technologies and newer softwares and things, see how they respond, right? Because at the end of the day, it's also a sales position. So I used it and she was absolutely thrilled. And not only that, like she got it on her first burn, it terminated the flutter. So it was like a really satisfying map that I had done. It was a really satisfying case. It was kind of the moment for me where I realized I think properly transition from being a trainee or being kind of like a newer mapper to really
Right.
being more reliable and experienced mapper, and someone who the physician can be like, oh, okay, like I would, I'm comfortable with her solo covering my case instead of, having like somebody else there with her, and the physician ended up liking that tool as well. So I've been trying to use it a little bit more in different cases since then, and she's responded well. So that was one of the cases where it was really satisfying. It was a different type of flutter than you would expect, and we got it. And um,
It
I
was a team
like,
effort, and it made up for a lot of bad days, right? And
right.
you
Oh,
haven't been,
yes, for sure.
yeah, it made up for a lot of, and that's perseverance because you haven't been doing it this long. Have you been doing it a year, 2 years?
I mean, yeah, so just 1 year goes into training. So the first full year was purely just training, getting your hands on.
I got it.
Uh Being, you have a mentor there with you, so even though you're the one on the mouse and keyboard and doing the mapping, there's still a lot of oversight. After that, once you're signed off, they sort of ease you into solo case coverage without any oversight. So it's been about a year and a half now, uh in total, and I guess 1 year was just training, so literally almost half a year now I've been
Wow. Wow.
flying solo in the position.
Yes. Yeah. I'm sure you've had to overcome plenty of butterflies, but I'm
Oh
glad
yeah.
you persevered. Can you bring us back to college,
Mhm.
freshman? It sounds like I even looked at your LinkedIn. It sounds like you kind of volunteered at Center State Hospital, things like that. Did you always think about healthcare? Was that where your mind was?
Yeah, I was always interested in a clinical and healthcare environment, but also was really interested in research. So especially in college, I was involved in a research lab at Case Western's med school. So I loved, the actual like acquisition of knowledge and testing and everything like that, and things experimental as far as therapy goes. But I was looking for some way to combine the two. So I think that's kind of where I tried a bunch of different things to see where I could find something that would intersect them. So like, first working in the research lab, then realizing there's no real clinical aspect to that, with just
No.
experimentation all day. Then I worked as a scribe at Central State, and that's purely clinical. And you're shadowing a physician, you're writing down their notes, they're seeing and assessing the patients, diagnosing them in real time. But then there's minimal involvement as a scribe as far as the clinical setting with actual treatment and also the research. So that was kind of where I was going along with that, is trying to get as much experience in the related field as possible with different things to see what clicked with me and what didn't.
So this is typical of so many students, except you put in the work. I'm sure you were conflicted as you went through your didactic training and prerequisites of chemistry and biology and calculus and
Yeah.
so many difficult courses.
Right.
Uh, when did you decide to do the master's? Were you still thinking about going the medical school route? Not sure did the master's, where was your mind? I want people to hear the truth that no one really knows, or very few, I should say, really know what they want because you don't know what's out there. Like you said, where was your mind at?
Yeah, so as a senior at college, or finishing up, ready to graduate, I was in that position where I still wasn't really sure what that meant as far as a career in biomedicine. Like I tried looking and reaching out to alumni, but I still wasn't sure if that was what I really wanted. But then I was also getting, this pressure from my parents who were
Sure.
saying, you need to be doing something and you can't just, graduate and have nothing lined up. And especially with COVID in the midst, like it was just a really kind of
Terrible.
stressful environment and time for us both, where we, both were unsure of what my future meant for me. And I was also in that position where I wasn't even sure if I wanted to do medicine or not, because it seemed probable, like, especially if you finished a major in biomedicine, you always think, oh, well, maybe medicine wouldn't be so bad. Like if it's more of just biomedical engineering similar, let me just take these courses and let me just shadow a little. I mean, I've anyway done almost all of it involved in my biomedical engineering curriculum anyway. So I
Right.
was like, oh, maybe that is something I want, even though I was on the fence about it. So because I still hadn't fully committed to one thing or the other, the reality was that by the end of my senior year, there were still, even if I wanted to go into medicine, there were a lot of things that I was missing from my portfolio. Like if I wanted to apply to medical school, I still needed to have done shadowing at that point, or I still needed to have finished a few more courses here and there, and also needed to maybe have a more competitive GPA. So that was kind of when I started looking into master's programs, and specifically ones that would be geared towards tailoring your academic profile for medical school and kind of building it up uh, so that you become a more competitive applicant in the later future. And that's how I came across like a master's in medical physiology, where you would be able to take some courses from Case Western's medical school. If you performed well and really committed, got your GPA up, it would show a transition and it would show that you have the academic rigor. And then there was also a bunch of opportunities within the program for you to get some more clinical experience or complete anything else that you needed for your overall profile in order to apply. And since I was unsure, I thought at least if I do this, if I do decide it, then I'll be set. And it's still along the vein of biomedicine where it would be clinically relevant and the classes would be interesting. Um, so that's kind of where I went from there.
Yeah.
It was something where it was like, you'll still be doing something and not just, like kind of sitting idly waiting for something to happen or like applying to things and not knowing, like, at least if you have a master's lined up, you can do that. So that was kind of the thought process behind me going into the master's in the first place.
And it was very prudent. My son did the same thing, and you were so empathetic when you said it was such a hard time for me and my parents.
Yeah.
It's a hard time because as a parent, my son was in a similar situation, very similar, but I didn't want him to graduate and sleep until noon or,
Yeah. Yeah.
squander time. I felt incorrectly like for every minute he wasn't actively doing something, we lost something. And I
Right.
unfortunately I put a lot of pressure on him. But he did a master's program also. And what that did is give him time to grow up, give him time to think,
Mhm.
space to
Yes.
think, and to
Yeah.
kind of get his shoes underneath him and
Mhm.
get his dad off his back probably also. But it,
Yeah.
it, it is good advice if you need that. I think a post-bac program or something
Right.
like that, a master's program that leads to a degree and gives you the opportunity to find this field that
Right.
you found, and you seem very happy. It seems to
Mhm.
fit your lifestyle right now. You're an integral part of the team. You could honestly say, without you, it doesn't get done. And the
Yeah.
quality of how you execute the software and your decision making in real time determines someone's life sometimes.
Right. For
So,
sure. Yeah,
so you
definitely.
have a lot going on there one time, not only the electrophysiology that you have to learn to do this and so much more.
Hmm. Yeah, for sure. I think I definitely just needed the time aspect more than anything else. But still have something with a structure where I was doing something productive to keep myself
Yes,
going.
and you were meeting people along the way and visualizing yourself in this direction, that
Right.
direction. You can call it happenstance that your uncle came to you, but at the time you were ready, right? The teacher
Right.
appears when the student is ready.
Yes, exactly.
It's kind of like if he came to you maybe second or third year, you're like, no, I don't know, I don't
Yeah.
want to give up on, you have all these thoughts, these ideal thoughts, but you're
Mhm.
not giving up on anything. You're really trying to find your way.
Right. Exactly.
So let's say you're in high school now, you're 17 years old, knowing what you know now, almost 10 years later, what advice would you give yourself? Having gone through all this apprehension and, you know, anxiety, I don't know what you want to call it, unknown uncertainty, let's call it that.
Right.
What advice would you give to yourself? We'd say, Rashi, listen to me. Listen to me. What advice would you give yourself?
I think the most important thing I would say is don't be afraid to explore or even just reach out to people. I think like one of the things that was really limiting for me personally is just that kind of fear and uncertainty that comes with reaching out to even, like I said earlier, reaching out on LinkedIn. You're putting yourself out there, and that's
Yes,
something scary and that's something new, especially, if you're that young and then you're in high school. And you have a lot of things influencing things like that, like, oh, like, does this seem embarrassing? Am I going to be judged? Is this going to be weird? But I think that being vulnerable and then allowing yourself to just explore and step out of your comfort zone a little bit will really pay off later on. Like, as long as you're, doing it in a safe and a structured way, it's really important to get yourself out there as earlier as possible so that later down the line your options really open up and you get a more broad sense of what is really out there and what is possible. I think a lot of the time, like for me, what was limiting is just not being aware of what fields exist, what jobs within those fields exist, where different fields intersect, and then what jobs come from that. Like, I wouldn't know that without exposure to those things, and the exposure can only come from reaching out to people and not being afraid to explore, do research, put in that extra time. It seems
yes,
boring, and it seems like no kid wants to like, I'll sit down and do an hour of research of like what jobs are in biomedicine or like what jobs are in cardiology. But
right.
if you do it now, then it can lead to potentially all these contacts and things that you can shadow, and then even 2 3 years later you could be like, oh hey, I've really realized that this is what I want to do, and I remember shadowing you from in high school. Like, I would love to see you again and meet you again and get a better sense of what you do, and I think that would really pay off.
I think that's great advice. And we talked about it earlier, and I want the students to know, and I'm talking to myself, is rejection is part of success. I
Right.
think I do my research, but like you
Mm.
said, I hesitate to reach
Right.
out to someone
Yeah.
because I am afraid they're going to say no or they'll ghost me or not respond.
Mhm.
And the more you do it, the more comfortable you become.
Right.
And number two, it's not personal. If the person doesn't get back to you, it has nothing to do with you. It has to do with where they are in their lives at that particular point in time. So
Right.
I'll share a personal story with me. We didn't have LinkedIn back in the day. We had work. And the
Mhm.
way I became an optometrist, it was very similar to you. I'm in college, uh, want to be related to healthcare field, not certain if I wanted to endure the rigors of medical school. And I started working. And to get a job back in the day, you had to apply to many jobs in person.
Mhm.
You and you know how many times people said, no, no, no. And then I get a job.
Mhm.
And it just so happens the owner's son was an optometrist. And I said, oh,
Oh,
what does an optometrist do?
right. Oh my
It's
God.
just that silly. They said,
Yeah.
oh, optometrist does this. You have to be good in physics and you have to be good in math. I said, I'm good in physics and math,
Yeah.
but I can't spell very well. Oh, you don't have to spell. And that set my career path in something that's as serendipitous as that. Same thing as your uncle, right? It's kind of
Right.
like when you're ready. But if I sat home watching TV, hoping someone would tell me what to do, it would not be as gratifying and I wouldn't feel as good in my career. So I think your advice to your 17-year-old self is good advice to all high school students
Mhm.
is don't be afraid to connect. Don't be afraid to get rejected. It's a necessity for success.
Right. And honestly, sometimes those rejections, you never know, are what is leading you to your ideal path in life. Maybe that's just what's necessary. You don't know yet. So
That's
you won't
very
know.
profound, but very true, right?
Yeah.
That's very true. We think our successes lead us in the right path, but maybe sometimes those rejections we fight for are telling us go into a
You
different path.
right. It could be a blessing in disguise, and you
It
wouldn't know.
often is. It
Yeah.
often is. Well, Rashi, I'm just so proud of you. Just seeing the smile on your face. I couldn't do what you're doing. I started sweating when you were telling me they're having palpitations during the procedure. And not only did you keep your cool, but you said, "Hey, let me introduce this instrument that other surgeons are using. That's what I'm
Mhm.
here for." And it
Right.
turned out to maybe save that patient's life because you cut down that procedure time
Right.
significantly. And the
Hmm.
surgeon knew it and you knew it. And the patient probably doesn't know it, but I'm sure they're grateful that you were there.
Yeah, for sure. Thank you so much.
Okay, thank you. So until next time, everyone, have a great evening. Bye-bye.